Mr. Chairman, ladies and gentlemen, we have seen before the different aspects of pneumothorax, primary, secondary, and there is the third one that is catamenial, when the condition is related to the menstrual cycle. Have a look at the epidemiology. Epidemiology is different from 16 per 100,000 population per year, and it's, of course, most common in men. I want to stress that the lifetime risk of developing pneumothorax, either primary or secondary, is related to smoking. Smoking males, 12% versus non-smoking males, 0.1%. Have a look at the national guidelines. Guidelines have been published by the American College of Chest Physicians in 2001, by the British Thoracic Society, 2 editions, the first edition in 1993, the second 10 years later, the third one is expected maybe in a few months. Then we have the guideline of the Belgian Society of Pneumology and the guidelines of the Spanish Society of Thoracic Surgery. There is a new guideline on which we are working on, and this is the European, the ESTS task force. The guidelines are expected in 2 years. In the task force there are thoracic surgeons and pneumologists, 6 versus 4. Chairs are Mark Krasnis for the STS and myself for the ERS, and there are members from different countries. What's the aim of therapy with spontaneous pneumothorax? Of course, is the elimination of the intrapleural air. We have observation with bed rest if it's only a small pneumothorax, or evacuation that is most common. The secondary aim is to prevent recurrence when there is a high probability of recurrence of pneumothorax, and of course pneumothorax is very has very high recurrences rate. Observation should be the first line treatment in partial pneumothorax, and it's a grade B recommendation. It's a high grade for pneumothorax in which there are very few randomized controlled clinical trials. So we have grade B and grade C recommendation, very, very few grade A. But this is, of course, a procedure that takes a long time and now is unacceptable. Thoracentesis. There are several randomized clinical trials that have shown this procedure to be very effective. Of course, as surgeons, we are reluctant to use thoracentesis. We prefer drainage, but there is a grade A recommendation from different clinical trials, and I think even we have to review our practice in this phase of pneumothorax. Thoracentesis is associated with less pain, and the patient are not be admitted to a hospital, so there is a cut-off cost. The rate of resolution is very high, between 50 and 88%. What we can use for thoracentesis? Venous catheters or small bore chest tube that must be removed once the expansion of the lung is confirmed, so directly after the procedure is done. We have not to leave a catheter in situ, otherwise it's not a thoracentesis. It's a drainage. Drainage can be performed with small bore catheter, or as, of course, it's our practice with intercostal tube drainage, 16, 20, or 24 French. We have just discussed, is it correct to offer surgical treatment in the first uncomplicated episode of pneumothorax? From a theoretical point of view, it is correct. From a practical point of view, we believe that because of the cost, because of the time needed, I think that there is no reason up to now to offer immediate surgery for uncomplicated pneumothorax. When there is an indication for surgery, recurrent pneumothorax, second episode or more, I think is a must to offer surgery. Persisting pneumothorax. What is persisting? For me and for most of the surgeons, 4 days of air leak means persisting pneumothorax, and it should remain surgery in every patient. Then there is hemopneumothorax, bilateral pneumothorax, first contralateral pneumothorax, and of course, professional at risk. Football players are people who have a high risk of pneumothorax, and we have operated a lot. Well, probable CT scan. In the previous presentation, we have discussed about what to do. There is a need for CT scan. BTS recommend using CT scan when there is a need to differentiate between pneumothorax and bullous disease, when there is an aberrant tube placement, and when the plain chest radiograph is difficult to read. And it's a grade C recommendation. But there is another point that I would like to address. CT scan is required before surgery in patient over 40 years old. Why? We have to rule out lung cancer. Absolutely. You cannot do VATS and pleurodesis in a patient if you are not sure there is nothing inside the lung. So I think this point should become, in the near future, a grade A recommendation. Absolutely. What surgery offered to patient? Is VATS the gold standard for spontaneous pneumothorax? In a paper I published in the Annals of Thoracic Surgery, a colleague, when I wrote VATS is the gold standard, in the discussion said VATS is the copper standard. So I'm not in agreement, of course, with him. Some years have gone. This paper was published in 2000 in the Annals of Thoracic Surgery. Now it's 10 years later. I would like to stress that up to now, VATS represent the gold standard. Even if some colleagues from UK where I work, I'm not in agreement. We have a look at what is published. Systematic review. There is a paper by Sajakam published in the British Medical Journal 6 years ago. He recollected 670 patients from 12 randomized clinical trials, and he found for VATS less hospital stay, less pain, less recurrences compared to Prevaldane, and comparable complication compared to surgery. Now we go on with another systematic review published in The Lancet in 2007. There are much more patients, more than 3,000, but there are only 4 randomized clinical trials and 25 not randomized. VATS show an overall recurrence rate of recurrence pneumothorax 4.73%. Very, so it means that 4 times, at least 4 times, is the recurrence rate of VATS compared to thoracotomy. Then there is a best evidence topic, published 2 years ago. VATS, less hospital stay, less analgesic requirement, but again, 4 times increase in recurrent pneumothorax. What's the problem? There is a bias, of course, of review. Systematic review, as we see in the next session, need to be very carefully read. Have a look. The first VATS operation were reported in 1992. 15 of the 29 studies published in the Barker analysis had reported by 1997. So these operations were done in the first 5 years of this procedure being adopted. And this must be kept in mind. A few years ago, the variation in use of this procedure was very high. And for example, in UK practice, it was from 0% to 100%. It depends on the hospital. So we have to put together not apple and pear. An outcome from 10 years ago might not reflect the present result. Early and late pain is less common in VATS, and this is absolutely clear for everybody. And we have to keep in mind that this is a benign and self-limiting disease that afflicts young people, that are that they don't like at all pain, and they are difficult patients. Thoracotomy is, in our opinion, unnecessarily severe intervention for this, for prevent these very few recurrences, if they are. Furthermore, patients who have a recurrence prefer to reply VATS than to go to thoracotomy. So, as a summary, VATS provides similar results to thoracotomy with respect to prevention and is associated with fewer complications, less pain, and a better cosmetic result. Bullectomy with pleural abrasion is the technique most often used by most thoracic surgeons. Bullectomy with talc-podrage offers similar results in terms of safety and long-term recurrency, as we published in the Journal of Thoracic Cardiovascular Surgery, with a very few recurrence rate. have a look at bullectomy. There is no grade A recommendation to support bullectomy unless bullae are broken. Neuheim has shown recurrence rate diminished from 20 to 1.5% with bullectomy, and myself shown bullectomy to be superior to bullae ligation. But anyway, we have to keep in mind that unless the bullae are broken, there is no grade A recommendation to cut. Pleurodesis. Again, no grade A recommendation. That means randomized clinical trial. This means grade A. 3 not randomized clinical trial suggest bullectomy without additional pleurodesis or pleurectomy does not prevent recurrence. Again, Hoyle has shown recurrence rate diminished from 16 to 1.9% with pleurodesis. And these are the 3 not randomized clinical trials that provide this support for pleurodesis. Which option? Total pleurectomy, apical or partial pleurectomy, mechanical pleurodation, apical pleurectomy plus abrasion down the diaphragm, and chemical pleurodesis, that is talpodage, that is very common. In conclusion, for spontaneous pneumothorax, bullectomy plus pleurodesis is strongly recommended, but blind apical resection is not recommended. What's about secondary? A very quick overview. Observation is still the first line of treatment, but drainage is more often required. The estimated recurrence is higher, and additional treatment to induce pleurodesis should be considered because the pneumothorax itself is a predictive factor for mortality in patients with COPD. What's about the guidelines? The ACCP recommend chest drainage followed by pleurodesis to prevent recurrence, even if in the ACCP guide was a consensus conference, the Delphi, so 90% of the experts recommend not performing pleurodesis until the second episode. So there was a disagreement in the panel of the American College of Chest Physicians to recommend pleurodesis in the first episode of secondary spontaneous. The BTS and the Belgian Society of Pneumology recommend simple aspiration as initial treatment and drainage if there is no early resolution. All the 3 guidelines recommend chest drainage if the patient is unstable or there is a complete pneumothorax. Which is the recommended surgical procedure? It's VATS with abrasive pleurodesis, talpodage, or apical pleurectomy with or without bullectomy. In case of failure or in case of contraindication, there is a need for thoracotomy, but only in case of failure. There is another option that can be used in patient with a very high risk patient, that is Stark-Slary, that has been shown to be effective in patients with severe COPD, and of course, it should be reserved for patients in whom surgery is contraindicated. Overview to catamenial pneumothorax that occurs during menstruation. There are different etiology for this pneumothorax. Most important, we have to keep in mind that there are 2 groups of patients who have diaphragmatic defect or patients who do not have. So it means that the diaphragm must be very, very carefully inspected, and VATS is superior to every technique to inspect the diaphragm, absolutely. There has been proposed the suture of the diaphragm, plication, resection of the membranous part of the diaphragm, or pleurodesis. What we recommend is conventional ablation of the parietal pleura or talpodage, complemented by local treatment of the diaphragm. Now, just an overview of my series. We have treated 1561 cases up December 2009, and this represents 26% of our VATS performed. We use Van der Schuren classification for our protocol, and this is our protocol. Stage 1, that means no adhesion, no bulle, talc powder only. Stage 2, that means adhesion, we take away the adhesion and we do talc powder. In stage 3 and 4, we do stripping of the blebs and bulle and talc powder. Even if in an recent series we are trying to do no-knife treatment of the bulle. Just we use a no-knife stapler to avoid communication with the air, and then we do talc powder. But I have no data to support this activity now. What's about talc? We will see periodicity, so I don't want to go on. Just to keep in mind that there is a paper, the SOTIP paper, that means safety of talc in spontaneous pneumothorax. We have done a multi-center study with the European Respiratory Society, and the paper has been submitted for publication. I hope to present the result. Just to keep in mind the size of fibers, keep in mind that it has versus-free talc, sterilized talc, the range, the dosages 2-4. Keep in mind the fibers because the European talc is very different from the American talc. This is to show the percentage of particles in the talc, just to show American colleagues that the problem of adult respiratory distress syndrome is related to the size of the fibers, not to the talc itself, as some people say. And this is to show the safety of talc even in young people. Very, very few complications. Conversion rate very low. Overall recurrence in this series of 861, that is the biggest of the literature, was 1.73%. Just a look to the smoking. Smoking habit have a relation even in primary spontaneous pneumothorax, not only in secondary, as somebody says. Absolutely. There is a P of 0.037. And this is important in the counseling. When you speak with patients who have been operated for pneumothorax, remind people not smoking if you want to avoid recurrence. This is a very point that must be stressed. This is a slide just to see the recurrence rate in the different series of the literature. Is there a need for follow-up in patients with pneumothorax? A difficult answer. In my institution, we do follow-up 1, 3, 6 months, and every 1 year for 5 years. Is it too much? It's a point that can be discussed because follow-up means money. So it costs money. This is just to show that there is no lung function impairment following talc powder, as has been said. We have done a study on 2 groups of 50 versus 50 patients, surgical treatment versus simple drainage only. And pulmonary function showed no statistical significant impairment between group A and group B. So in conclusion, we believe that VATS represent the gold standard for recurrent and complicated primary spontaneous pneumothorax, as it allows for shorter hospital stay, less pain, and quicker return to the activities of daily life compared to open thoracotomy, which is important in this young, otherwise healthy patient population. Talc pleurodesis has been shown to be a safe procedure to preserve lung function in the long term and does not restrict chest wall mobility. I thank the association for the privilege to present this series.